we're going to introduce my boss. Very excited to have him here, of course. Dr. Stephen M. Dahmer is a board-certified family physician whose passion for health and healing has taken him around the globe. A fellow of the Arizona Center for Integrative Medicine for over 2 decades, he has studied the relationships between plants and people, working closely with diverse cultures and documenting their uses of plants and other integrative therapies. Since 2015, Dr. Dahmer has served as the Chief Medical Officer for Goodness Growth Holdings / Vireo Health, a physician-founded, patient-focused company dedicated to providing best-in-class cannabis-based medicinal products. He is also the co-chair of the USCC Medical and Research Subcommittee, actively engaged in clinical trials specific to cannabis, and has written and lectured extensively about plant-based medicines. As Director of Holistic Primary Care, Dr. Dahmer actively practices integrative family medicine in Scarsdale, New York, and remains active in academic medicine as Assistant Clinical Professor of Family Medicine and Community Health at the Icahn School of Medicine at Mount Sinai. Please welcome Dr. Stephen Dahmer.
Thank you for the introduction, Paloma. I have a lot to cover. 30 minutes. Plants as medicine. I always, not really joke, but I say that I'm biased, right? So here I am in the cannabis industry. I think it's all important for us to kind of admit our bias, and I'll say that first and foremost. I also say I'm biased because I'm a biophiliac. I believe that nature does something that we don't quite understand fully, and I love science. I'm enthralled with technology and science, but we're approximating the mysteries of nature, and I'll get into that a little bit more and a couple other credentials. I put this on every deck that I share, which is so unfortunate, and we've heard this 100 times, right? Schedule 1, no medicinal value whatsoever. There's my disclaimer. So I consider a mentor of mine, Dr. Michael Balick, and Dr. Rick Kingston, who will be speaking next, knows him well and has taught me many things about plants. And in my travels around the globe, realized, moving outside of New York City, that not all drugs come from the Duane Reade or the Walgreens on the corner. And in fact, for the world's population, the vast majority rely on plants as that first line. And this triggered questions in my own head as a physician constantly looking to learn. Why is that? Is it just because it's grown in the backyard, because it's cheap, because it's what they're used to, because they don't have access to our amazing pharmaceuticals that we have here? Or is there something more mysterious, something else to unravel? And I discovered, too, that I wasn't taught in med school that the majority of our pharmaceuticals do come from plants, right? And here are very specific stats on 57% containing at least one major active compound from plants. A couple examples of metformin, which is a very common first-line diabetes drug, again, mirrored after plant molecules. They are our greatest treasure trove of even pharmaceuticals. And we haven't scratched the surface. And, Dr. Balick does this far better, or even Dr. Stephen King, really arguing for protecting biodiversity in the world because this treasure trove has millions of molecules waiting to be discovered that we don't know how that's going to impact our chronic pain, our inflammatory bowel, our fill in the blank of our diagnosis, or as I'll argue a little bit more, just even our overall health. Majority of these have not been studied scientifically, and really the vast majority of plant compounds, we're not even aware. Our closest friends here, the plant kingdom, we know I just heard a quote yesterday that we know more about the surface of Mars than we do about plants on this earth. In our current paradigm, which again, I am not anti-pharmaceutical. I prescribe medications regularly as a physician. I utilize them regularly. I think there's tremendous value in the pharmaceutical model. But it is when we say in integrative medicine, when all you have is a hammer, everything looks like a nail. And our current paradigm is one drug, one receptor, and that drug only interacts with that receptor, very, very highly selective, right? And so we're really trying to hone in a reductionist model we take, right? We've talked about the plant, and I'll talk a little bit more about this, and its tremendous diversity and the chemicals that exist in that, and we pull it down to a single one. And then we supersize that in a reductionist model, and we study that to try to and I'm paraphrasing here a little bit, or I'm simplifying, but reduce the noise, right, that can occur with these plant medicines. And that single molecule, single target, single drug has absolutely dominated our pharmaceutical model throughout the entirety of the pharmaceutical industry. And in the history of the FDA, there are only 2 botanical drugs, right? Botanical drugs mean that they try to mimic or resemble that plant or the compounds that are in that plant. Anyone want extra credit? Guess the 2 botanicals that have gone through the FDA process. Who said that? Oh, great. Great guess. You're wrong. Aloe is an amazing plant with healing potential, but has not gone through the FDA process. Any other guesses? So green tea is one. It's a topical FDA preparation used for genital warts that has gone through the FDA process and is considered a botanical. The other is what's called dragon's blood. It's a beautiful tree from South America that has gone through the FDA process to treat non-infectious diarrhea associated with HIV. And those are the only 2 out of thousands of pharmaceuticals that are botanicals. And some, for a long time, argued that Epidiolex, right, might be a botanical, but it truly is not. It's far more an isolate than a botanical. And the reason that we say they haven't gone through this process is because they're so dirty, right? They interact with so many different things, and we're used to one constituent, right? Not multiple. It's very difficult to study in a reductionist model. We're concerned about all these chemicals then get metabolized into our body, into other chemicals, and then how does that interact with multiple different systems within the body? And this has really biased us in the medical industry to turn away from plants. And many would probably argue that there are 1,000 other reasons to focus on the single constituent, but in many ways it's just too complicated to study in many of the models that we use, despite numerous examples of plant medicines being very safe, including cannabis. And I think this is what's going to really tip the scales towards what I hope will be at least a partial paradigm shift to embrace plants more specifically in chronic disease. Our medical system is incredible in taking care and addressing acute disease. I always joke, I don't joke, if my leg is severed or I break my leg, I'm not taking a plant medicine. It might be part of a therapy. I'm in New York going to the hospital for special surgery to have that reduced and for me to go to an operating room, right? But the majority of what I do, even as a clinician, is not sudden onset, short course. The patient kind of sits and has things done to them. The physician dominates, or someone's even under anesthesia, and you're likely to return to normal very quickly. The majority of what I do as a family physician, and what most of us do, falls under this chronic care model. It comes on slowly. We kind of don't know which direction it will go. The patient has to be incredibly active, otherwise we're just putting a drug or a Band-Aid on something. And this change to real focus on chronic disease, which is where our medical system is headed, is what's going to shift to look to other models to address that. And it's the true healthcare crisis, right? 50% of the U.S. population with chronic disease, 86% of our costs. And many would argue that the United States is struggling with COVID so much because we have not addressed the chronic disease epidemic. And I actually borrowed this from a recent podcast where they were talking about, and I'll even call out Elisanda, who's at a company called Brightseed, where they're using artificial intelligence to map all the chemicals within foods. And she said, there's a dark side to our plants that we don't know. And for me, it just, really a light came up. There's a dark side to our health that we don't know. The human microbiome, everyone's heard of it? I was in residency. I got a probiotic on our formulary. That means in the hospital I could write and a patient would receive that, and everyone made fun of me. They called me Dr. Probiotic. Where is the evidence base for this? And how many people have heard of a probiotic? How many people have taken one? Right? And even it's still debated, but again, the microbiome is just this fascinating area of human health that we don't know anything about. The endocannabinoid system. Only recently we discovered that. The runner's high, and I'm sure you guys will hear this in other lectures, all these things are starting to be attributed to it because there was this dark matter of health. We had no idea what was going on. Mind-body interactions, which, again, I count Dr. Andrew Weil as a mentor who's just a pioneer in addressing this mind-body interaction that for the longest time we haven't talked about. Let's get into the plant, right? Oh, so pretty. Right, isn't it? Oh, just so amazing. I'm an amateur gardener, too. Amber Shimpa is an amateur gardener as well. Reintroduce, you guys have seen this, right, 1,000 times, annual flowering herb. You know, some estimates, I always say that I need to update the slide, and I never do. 38 million years old. A plant that's 38 million years old, 60 unique compounds. This number keeps going up. I can't keep up with it. Delta 9 we know about can cause a high or intoxication. CBD, you know, is psychoactive but won't cause the feeling of intoxication. And, you know, thousands of years used as a medicine, right? And it was really Professor Meshulam that discovered anandamide that really changed, in my opinion, kind of medical science and the medical industry, their view on cannabis, because all of a sudden we had a single constituent, right? And that would be THC, kind of mimicking anandamide. I think this slide is really important, and it's really busy, but I really want to delineate the difference between these. So we talked about, and I guess in the CME track, we talked about anandamide, which our body makes. It looks very similar to THC. And our body makes this, and it works on the same receptors as the THC from the plant, right? And ananda comes from the Sanskrit word bliss. And we're discovering more and more chemicals that our own body makes. And this is true of kind of any psychedelic or the majority of plant medicine. They're mimicking constituents or chemicals our own body makes. These are endogenous. Our body makes them and utilizes them. Phytocannabinoids come from the plant, right? And we're learning more and more about these versus a synthetic cannabinoid is what we produce in a lab. And the argument that I'm trying to make, right, and again, I'll put some science behind this too, but we have long ways to go to prove this, is that there's a marked difference between a synthetic cannabinoid and a phytocannabinoid, especially when the phytocannabinoid from the plant is delivered in that kind of similar to original container, right? The dance of these molecules, which we'll talk a little bit about entourage, is very different than I give you a synthetic THC, and down to even a molecular level, we're talking a partial agonist in terms of phytocannabinoids. That means it binds and releases, right? It's a little bit more of a dance, let's say. Then a synthetic, which will be a full agonist. Think of a dance partner that doesn't let you dance with anybody the rest of the night, right? It's very aggressive, and even recently we're seeing upticks in news of fatal overdoses from synthetic cannabinoids. So the question I keep asking is, why do we die from a synthetic and yet we don't from a phyto? And why are so many people, when we've had since 1985 an FDA-approved THC, going to the plant? Is it just novelty, or I want to be a rebel, or is there something truly there? Obviously, you guys know my thought on that. And just a reminder of some of the pharmaceutical grade medications, and these work too. I've been very critical of them myself. There are many physicians that utilize these, even a synthetic THC. The argument I'm trying to make is there could be a better path, right? When we start to examine and start to look a little bit more closely at nature. And Dr. Layfeld and I love to say this is a plant of 1,001 molecules. It's not quite 1,001 just because we don't know them yet, right? We'll get there. We'll get to 1,001. But look at the richness, right, in this plant. And again, I'd like to take even just the first three levels. Everybody knows THC and CBD. Minor cannabinoids, we're starting to hear. Everyone's heard of CBN, CBG. I've been giving lectures like this for 7 years. I used to ask, has anyone heard of CBD? And not a single arm would go up, right? And these are moving very, very quickly, almost too quickly in my opinion. But the point here is, wow, how incredibly rich this plant is. Another slide to kind of reinforce that, right? Of the compounds, this slide is old, 104 cannabinoids, all of the potential impacts that can have on our physiology. And this is something that, again, I love studying kind of the history of medicine because I think there are just pearls there. There are wisdom that, as much as infatuated as I am with AI and technology, let's also learn from the past, right? Make new friends but keep the old. One is silver, the other is gold. We sometimes forget our old friends that admixtures really are part and parcel of shamanism or herbal medicine for millennia. How do we find different things to synergize, right, with that? And in many ways, pharmacy is mimics to that. The closest I found, and probably others can describe this better, but are even like excipients, right? So we put things in a pharmaceutical so it absorbs better or so it lasts longer. Basically, we're trying to harness that single constituent in our medication to work better for that patient. And we're starting to look, polypharmacy is actually an issue. That's where many of our elders are on multiple medications and they interact. But polypharmacology, right, is can we use multiple drugs on different targets? That for me makes tremendous intuitive sense. As a clinician, I oftentimes use adjuncts. And so an easy way to describe this is in pain, and we sometimes call it layering. I might have a patient on a smaller dose of Tylenol, also if they can tolerate it, some Advil, if they need that in opioid. And it's sometimes that layering which can get me to the lowest minimal dose, maybe of that one I'm most concerned about, the opioid. And we do that naturally. The plant has done that for us, right? And this is that idea, and I always put a Packer slide in when I come to Minnesota. Sorry, I grew up in Sheboygan, Wisconsin. But this idea that a whole is greater than the sum of its parts. And just because it is so intuitive in so many other areas of our life, orchestras, football teams, you're not going to take the quarterback and say that's the Green Bay Packers, right? It's intuitive in so many areas of our life. Doesn't mean that it's fact, right? But this lends us to, let's explore this more, because that interplay is going to be responsible for outcomes, and ideally positive outcomes, that when we just pull one out, we're not going to see as much. And there's a name for this, right? That's been termed the entourage effect. Dr. Leifeld and I like to call it ensemble. Entourage means there's a head, which everyone assumes is THC, a leader. Ensemble is like, hey, we're all working together synergistically, right? And that's why we've changed it a little bit. But the research, and I'm going to show you some of that, when administered together, this soup, we might call it, of chemicals, right, of constituents, can potentiate a therapeutic effect while mitigating side effects. That's a very bold statement, and obviously there will be nuances to it, but there's something there that we need to further discover and explore, and that's what we're doing. And I think we'll see other slides like this, so I'll get through it quickly, but it fascinates me that the two most prevalent cannabinoids, THC and CBD, have an almost opposite effect. And I'm really drawn, as I get older as a physician, to these interventions that help the body find balance. Rather than coming in with a sledgehammer, which is great for an acute issue, but for a chronic issue, how do we find our body's ability to come back to a balance point? And the plant does this by balancing itself, right? The THC can be related to euphoria, anxiety, psychosis, cognitive impairment, tachycardia at too high of a dose, oftentimes, but CBD almost the opposite effect. And when we lose that antagonism, we just pull out the THC, and you'll hear this anecdotally from physicians all the time. The dronabinol or the prescription is just too rough. There's just too many side effects, and it's a common thing that we hear. We lose that antagonism, and there's increased side effects and poor tolerability. And again, coming back to biophilia, you guys can hear me. I don't think you see the microphone anyway. But look at that cool fruit. You guys call it a fruit or a flower? Well, maybe we change that. Your botanical, there is some push towards calling that a fruit. Anybody know what these are? Dr. Leifeld can't answer. Trichomes. These are the factories where the magic is kind of made, amplified over here. All of that treasure trove of chemicals. And I just threw in here, I'll go through these pretty quickly, but we're accumulating this evidence that this entourage, there's something there. Many people know that, which is why they come, like, oh, it was such a huge hit in Minnesota, right? Why is that? What's the why behind the why? Because there's something to this, that the isolated cannabinoid may not provide the full benefit available to the plant. I got so many examples. Without this synergistic effect, THC could have lower efficacy, greater degree of negative side effects. These are accumulating more and more, right? Again, looking at a whole plant extract, CBD and standardized is more potent or efficacious than pure CBD. You know, obviously, I'm getting to the point of hundreds of these where they're accumulating. And the problem is that we have thousands of different products and little snippets here and there. And that's what we're really lacking in my opinion, in the cannabis industry. How do we start to really tie these together in solid evidence that's going to convince even more than physicians, potentially insurance payers and others. Complementary pharmacologic activities that may strengthen and broaden clinical applications and improve the therapeutic index of cannabis extract. It does exactly what we would look for in an excipient, right? And we had a lecture downstairs where we talked about the use of terminology. And what if we could call all of these chemicals in the plant very fancy excipients that really help the plant help us harnessing that endocannabinoid system. contribute to modulatory effects. Everyone's aware of terpenes and just the rich pharmacopoeia. The very small concentration of terpenes can actually contribute to potentially that effect. And I try in every lecture to highlight a patient. We talked downstairs about it is the 2-year Charlotte Webb. Haley is a patient of ours, that's Haley on the right, that I've had the pleasure and honor to meet multiple times, that really, again, intractable seizure disorder responded incredibly well to our products. What I am further enthralled with this story, not just because it's so touching, and I met the mother who told me she spoke for the first time, she walked for the first time after starting your product. Epidiolex was approved, covered by our insurance. The mother of Melissa's a nurse. Why am I paying out of pocket? Let's go get this, have our insurance pay for it. Did not see the same benefits, did not see the same potential with the isolate from Epidiolex. This is an N of 1, came back to our Cannabis Patient Center, our dispensary, to receive our product because that is what helps her daughter. And who better than a mom to know what's helping? So let's get back to this dark matter, right? And here we have crazy complex physiology of the human body and an incredibly complex plant, but can we move beyond some reductionism? And the beauty of it is that technology is advancing so quickly, many times on the back of artificial intelligence, that we can find mechanisms by which to understand that. People are clever. We are very, very clever. Nature is ingenious. How do we start to work together a little bit, right? And the endocannabinoid system, I'll digress a little bit. I got a little bit more time, right? Dr. Bloom is a stickler on time. Wow, this has been around 600 million years. This system in each and every one of our bodies. 600 million years. And what doesn't it do? These are just, CBD and minor cannabinoids. THC is not even in there, but everything. I mean, really, under the sun, there are few things that the endocannabinoid system in the body is not touching. Summed up in a slide, I think this was McPartland, who gave, really dumbed it down for us, I would like to say, that the endocannabinoid system helps us to relax, both physical and mental. Obviously, munchies we're all aware of. Supports sleep, especially onset of sleep. Protection, right? And this is such a general term, but immunomodulation, metabolic regulation, neuroprotection, cancer control, and the ability to forget, right? To take your mind off, and as we discussed with PTSD, can be so valuable. I see that there's even little clips of me on the internet getting excited about a homeostatic supermodulatory system, but a system that modulates or oversees our body's ability to balance, which is what homeostasis is. That's what the system does, and there are phytocannabinoids, there are phytomolecules that harness this system for better or for worse, right? And that's the trick that we have to find out, to harness this to do good. And then, further getting into the why behind not a lot. Any thoughts? Talking too much. In the back?
I'm sure you don't know why the AMA and the FDA want to lean on the DEA and say more permits for more science.
Yeah, they're working on it. So we just had something passed to increase research. That's a whole other lecture, though. It's I hear you, and you're preaching to the choir in that one. But I want to talk a little bit about plant molecules. Why are they interacting with our system? Right? Why do the majority of our drugs come from plants? And it's funny, I call myself a doctor that's interested in plants, and for the longest time I never even asked myself that. But here is a theory, right? For the first time, the idea of Xenohormesis, that these plants, when they're stressed, produce chemicals to support themselves and their longevity and their lifespan and their ability to reproduce in these times of stress, that we then as humans absorb and consume, and they trigger many of the same mechanisms for us. Cell stress resistance, energy metabolism, disease resistance, that there is a theory by which these plants, when stressed, and if you talk to a great horticulturist or someone that's growing our plants, we will put them through periods of stress. And the thought is the chemicals that they produce then can be ingested or vaporized or whatever your delivery form of choice is to help with adversity through increased survival, modulation of these target programs, and increased health and survival by harnessing the balance system, which is the endocannabinoid system. So for the first time, we have this potential mechanism by which it might work, right? And we have this system that we discovered in our own body by which it's harnessing that ability. And we're seeing absolute revolutions in similar fields. So this is like such a parallel for me as a physician to cannabis. Guess how many hours of nutritional education I had as a medical student? Close, but you're wrong. One, mostly related to TPA, right, which is intravenous nutrition we give in the hospital. And despite what we all know, the tremendous impact of nutrition on our health, we don't learn about it. And what a revolution we're seeing in nutrition, right? I was taught that a calorie from I always make up something Lay's potato chips, and get Lay's, is the same as a calorie from broccoli. No difference, right? A calorie is a calorie. We know that they're very different. If I have a diet based on broccoli versus Lay's, I'm going to have two very different health outcomes. And we know that, and this revolution is occurring as we speak right now in nutrition, to the point where we're seeing functional foods and a rise in phytonutrients. And I predict that we're going to see a real commingling of nutrition and medicine in the future. And right now, I have trouble sorting that out, even though they are so divided. And we have our pharmaceuticals over here, and we have our nutrition over here. We're going to see a tremendous commingling. And in cannabis, we're going to see that too. THCA, the acidic forms that come in the actual bud, flower, or fruit, whatever you want to call it, people are ingesting for potential health benefits, right? And that kind of falls into that food category, or even edibles. We're going to see a huge paradigm shift in that in the future. And this, for me, is just what personally has been a paradigm shift for me in my road on integrative and functional medicine, and the frustrations in primary care with the current medical model. We were taught to replace, fix, intervene, and it's modular. Meaning, I can't tell you how many visits I've had. I see you for 8 minutes. I've done urgent care. I've worked in the emergency room. I got 8 minutes with you. What are you getting when you leave? Quick physical exam if I got time for that. I write a script, and I hope you feel better. And we hope that that works, and there's the evidence to kind of support that. I fix you, right, with my prescription oftentimes, and then that's the end of our kind of relationship. What we're really seeing is a shift, especially with this chronic care, I would say burden, right? I hate to use that term, is we need to start to support the conditions, the soil, the sunlight, the nutrition, right, of us as organisms. And I see phytonutrients as a huge adjuvant, a huge supporter in that, whether that's through nutrition and food, or even what we call medicine from a plant source in the future. Someone else has to fix the machine, but the plant can heal itself. I'll be honest, to the physician, to reflect that to a patient is very empowering for both of us. I don't have so much pressure on me, and then we start to have a relationship where you've got to be involved. And I'm saying you guys, you know what I'm trying to say is that it's a relationship as different, a paternalistic, this is what you have to do. And we're going to see a huge shift in that. And, again, history of medicine, can we learn pearls of wisdom for that? Natural forces within us are the true healers of disease. Think about this for a second. I'll even take probably the most obvious glaring example of something I can do where I fixed you. You have a pneumonia. I give you an antibiotic. Do I cure your pneumonia with that antibiotic? No. I dampen the bacteria to a certain extent that your body regains health because it's not overwhelmed by the number of bacteria that are in there. It's our immune system that still goes in and finishes the deed, right? And so what we do is we're stacking all the odds in the favor for that balance to come back, including an antibiotic. And that's an extreme example of acute care. Imagine how nuanced it gets with chronic care. And these natural forces are the true healers, and the human body self-regulating, self-healing. We need to assist it with a little bit more subtle mechanisms in chronic care. We got 5 minutes. And again, we practice what we preach, right? And again, a big thing for me is that you don't just come to me to ask for a prescription and I'm going to cure you. The same is true in our cannabis patient centers. And so Sarah Overby, and with the help of many others, put this together. What can you do? Right, as a patient, what are the ways that I can naturally, and we're starting to see a lot more of this, and the research is in its infancy, but there are a lot of things that overlap with just good healthy behavior, but these are harnessing and supporting a healthy endocannabinoid system. If I were to say one term for endocannabinoid system, it's resilience. All of us are going to get sick in some way. How do we bounce back? How resilient is our body and mind to come back to a spot where we can still function and feel well? The endocannabinoid system is what supports that, and there are many things we can do in addition to the plant to support that as well. So here's my summary, because Paloma's giving me a few minutes left. Ensemble, phenomenon, prevalent nature, beneficial in many facets. Chronic disease, we're going to need a paradigm shift. The way that we're approaching chronic disease is not going to work. The nation will go bankrupt, just to be frank. And plant medicines, I truly believe, are uniquely suited to address that. Upstream approaches to balance and homeostasis are far underutilized. And this can be mind-body therapies. These can be things that are very cost-effective, very cheap, very few side effects. And I put plant medicine in that category. Support our own stress response to help that insomnia not be so extreme, not get to that level where it's disrupting so many things. And insomnia is just one example. Ensemble, again, potential mechanisms by which plant medicine could be more safe and effective. Additional research, again, we keep hearing this over and over. Let's research the potential positive sides of this. Medical community, which is really why we're doing this, right? We all need to be a pillar of education and support, offering answers to patients that are coming to us. And you know, this is probably the first kind of lecture I've given where I didn't go into potential addictive potential, that plant medicine is arguably, toxicology is one of the oldest professions, plants that can kill us. And so every medicine, including plants, can have a shadow side. But I think also research is what helps us sort that out. Who's the patient that will benefit? What's the right form? What's the right dose? Who might not? And how can we make those informed decisions? I think that's all I got. Yep. We'll open it up to some questions if we got a couple minutes here.
One or two.
One or two questions. Thank you for your attention, and